Good morning. Look who's here. Uh-oh. Why can't I hear you? I can't hear you. I can't hear you. You know. Uh-oh. Can you hear me? uh, well,
So I'm looking in the chat and seeing if anyone's coming in here, if they can hear both of us, because you might have yourself muted and somebody have me muted.
yowza. That just sounded like something from Mars. I did not understand anything you said.
Did you hear anything?
Ooh, shoot. Hang
I'll reboot.
Let me try this. Okay, that's not gonna work. I hear something.
Good. Do you hear me?
I do, yeah.
Okay, let us
Oh, man.
proceed.
Let's proceed with question number 1, which is going to kind of like get into question number 2. And welcome everybody. Good to see you. Okay. Question number 1, it's always going back to progesterone. This woman, sweet woman, is asking, what could be the cause of so many women who truly have an impossible time taking progesterone, and is there hope? Um, she's asking if there's a possibility that cortisol and adrenal issues might be at play in the way that somebody would process progesterone, and your feelings on that.
Well, how I'm interpreting what she's asking is that she's having trouble with progesterone.
Correct.
And can't get it right.
Correct.
And what I'd like her to know is this is a common issue. A surprisingly common issue because it doesn't make sense, because a young, healthy menstruating woman has 100 times more progesterone milligram per milligram than she does estrogen.
Right.
Wow, that's amazing. So her
I know.
body is used to progesterone, and of course, that accelerates astronomically if a woman gets pregnant. Both estrogen and progesterone levels rise dramatically
Yes.
pregnancy. But it doesn't even matter, even if she never was pregnant. Her body was used to 100 times more milligram per milligram each cycle of progesterone. And yet there's a certain number of women that have trouble with progesterone, and it's extremely rare. Can't even remember a case where a woman has any trouble whatsoever with estrogen or any trouble whatsoever with testosterone or DHEA. Why progesterone? Now, what we do with each individual woman, and I want to linger on that for a moment, that word individual. Um, we all are walking and talking, but the difference biologically from one human being to the next, the difference between one man to the next, or one woman to the next woman, to the next woman, to the next woman, there are wide ranges of what is normal for that woman.
Yes.
And just to give you an example, the internal ovarian hormone milieu of a woman who's tall and thin and with small breasts is very different than a woman who's short and curvy with large breasts. Just to give you a rather dramatic difference of the spectrum, when you look at the hormone profiles, how much estrogen there actually is, how much progesterone there actually is, what the ratio of progesterone to estrogen is in those individual women, it is dramatically different. So individuality has always been the key to the most successful treatment outcomes. And that takes time. I mean, and I'm a trained menopause method mastery provider. We know that it's going to take between 4 and 20 hours the first year because women vary so much. And so, no big deal. It's no big deal at all. We just individualize it. We just hunker down, take the time to figure each woman out. And with what this woman is having challenges with progesterone, we always begin at the beginning. It doesn't matter what the challenge is. We get an extremely thorough medical history. In fact, they fill it out online in the menopause method. It's 12 pages. Takes a
I've done
woman.
it.
Yes,
I
you have.
know. It was my thesis.
But it isn't trying to force someone into a difficult task. When I'm looking at one of these questionnaires, I designed it. My son and I turned it into the amazing online stuff that it is. We're asking all this detail because that detail tells me so much about the individual, and it comes down to, okay, what's the first step? So with this woman, she's got difficulty with progesterone. Well, I'd want to know many other issues around her situation before I could really address her specific individual situation. But I'm going to tell you one of the most common difficulties. This doesn't mean it's this questioner's difficulties. Is very commonly a woman had a hysterectomy and wasn't given progesterone, but was given estrogen. How I've always pictured it is her progesterone receptor sites just went dormant. And then by the time you get around to treating her with progesterone, you got very few receptor sites that are alive physiologically. And so instead of giving her the standard dosages of progesterone, we start with very low dosages,
Right.
gradually increase. For example, in the menopause method using the organic oils, we always start with progesterone 200 milligrams per milliliter, and we start at 2 drops, which turns out to be about 16 milligrams applied to the skin. Well, a woman who has progesterone challenges will start her out in 50 milligrams per milliliter. Therefore, she's at a quarter dose of that. She's at 4 milligrams applied to the skin. And we've gone down as low as 5 milligrams per milliliter. Oh my God. don't remember how low the drop is. So we
It's like for an ant, the size for an ant.
We start really low and we gradually increase. And how I visualize this, I don't know if this is true or not, is that we're gently trying to reawaken the progesterone receptor sites.
It makes sense.
This is not the only issue around progesterone. There are other issues of having a special immune sensitivity, otherwise known as allergy, to the carrier of progesterone.
Yes. Oh, I have a question about that too.
So some women, we have to change the carrier. But it's a little surprising because we're using a similar carrier for the estrogens and the progesterone, and they tolerate the estrogen, the bias, perfectly. So that's a clue that it isn't the carrier that we use. And then the provider that's the doctor that is most knowledgeable about this progesterone issues is Dr. Jonathan Wright.
Oh, yes.
Does electrodermal testing on these women with this special progesterone sensitivity. His laboratory, or the laboratory he's affiliated with, Meridian Valley Laboratory in Tahoma, Washington, Meridian Valley Laboratory, has a special mechanism of assessing this progesterone sensitivity. Maybe you would put that up, a link to their website, Meridian Valley Laboratory.
I sure will.
They have some kind of test. I haven't used it yet, but I think they send in a salivary sample or some kind of sample, and they try and assess what the cause of that progesterone sensitivity is. So this is a world that we haven't totally figured out. The one who's figured it out the best is Dr. Wright.
We do have someone here who is she's a patient of that Meridian Valley, sort of hit the whole Tahoma thing. And she's very happy.
They're the most knowledgeable about those progesterone sensitivities. So they do exist. And then, like, we have one patient, she had an early hysterectomy. She's always tolerated estrogen beautifully because she was put on Premarin after the hysterectomy. Now she's on topical bioidentical bias, that's for sure. However, she can take a very low milligram per milliliter progesterone about 2 days in a row, and then she has to pause for a day or two. So she's getting a trickle of progesterone in. And, you know, life, in case folks haven't figured it out yet, has got many challenges. And we got a zillion biochemicals that matter. And, you know, sometimes we don't get to have progesterone. We'd like to have it because it's fabulous and it's very important. But what I'm always, there's a lot of things that we're not getting. So I don't say the world ends because a woman can't get progesterone.
Okay, well, that's soothing, actually.
In fact, it's critical for us to get that at this stage of human evolution and individual development, there's a lot of things we're not getting. And, you know, the rule of thumb that serves me the best is to identify exactly what's going on for me and put my shoulder to the wheel and address the issues of deficiency of mind, of thinking, of emotions, of life, of wisdom, address them vigorously as I have for 50 years, and accept what's unfolding day after day. Start with acceptance.
I was just going to say.
Don't immediately say, I can't take progesterone, therefore I'm doomed. Because that was if I had to make a wild guess about the energy behind that question, life doesn't work like that. As humans, we're dealing with many, many deficiencies. And no surprise, they show up in the physical world as well because everything's multidimensional. So just start from where you are and figure out what, you know, inch by inch, what serves you and how you can tweak and improve your health gaining process. And it's not the end of the world if we can't get progesterone.
Well, if I may then segue into this second question, because it really is all about what you just said. This woman is very, very frightened that her inability to tolerate progesterone. Her doctor is saying that she really doesn't need it. She did have a full hysterectomy. And what she's asking is there a danger in not taking progesterone? Meaning, in not taking progesterone, does that contribute to the health of the heart, the bones, the muscles, everything you and I talk about, cognition, then the need for canes and walkers and wheelchairs and all that stuff. If someone is not
Yeah,
taking,
I
you get
get
it.
the question.
Yeah,
And, once again, it's a fabulous question.
it is.
And part of the question is there's been almost zero physicians who've specialized in treating women in menopause. For example, it's really in the realm of gynecologists, but folks have got to realize that so many physicians chose gynecology because they love surgery.
Mm,
And I wouldn't be able to practice today, or wouldn't be in the situation I am today, without the support of gynecologists throughout my 50 years of being a doctor. When I can think of so many gynecologists that have been so beneficial to my patients. I have deep, deep gratitude to the specialty of gynecologists.
absolutely. Yeah.
It's very rare, they do exist, that gynecologists also have specialized in the medical part of gynecology called hormones. And in medical school, it's a choice that so many students make somewhere along the line. Do I want to go the route of internal medicine, or do I want to go the route of procedures and surgery? And these are very, very different human beings. And you got devoted surgeons, procedure based physicians that serve the world wonderfully, but they're not necessarily, their love wasn't necessarily also internal medicine. As
Right.
a physician, for example, myself, I started out as a holistic physician, trying to cover a lot of bases. And about 25 years ago, I started realizing that I can't get my arms around this. I want to specialize. I want to zero in on something. And you can't do, there's so many moving parts to medicine that's the fact that specialties have arisen is no big mystery. In order for someone to get good at something, in the world of medicine or in the world of automobile mechanics or building or whatever, attorneys or whatever
Record
you want.
producing.
Yes, record producing. You realize somewhere along the line that you want to specialize, because that way you get to be good at something. So sorry to take drift there. It's in the world of treating women in menopause, there's very few physicians. This includes gynecologists or even functional medicine physicians who take an interest in hormones that have specialized. And the old thinking that emerged in the world of gynecology was that the principal function of progesterone was to balance estrogen and to prevent bleeding by balancing estrogen, prevent the production of an exuberant uterine lining. That's why women in menopause were treated with progesterone, to prevent an excessive formation of an endometrial lining and thus keep a woman menstruating, when a woman was treated with estrogen. So Premarin alone, horse urine derived estrogens, was later followed up by a progesterone that was a Premarin that was combined with an artificial progesterone called
I guess you didn't like it.
acetate. It's a It's a progestin, but why did they add Provera, the progestin, to Premarin to produce Prempro? Because they wanted to make sure that a woman did not form an endometrial lining and thus bleed from the use of Premarin alone. And so in the early days, when Premarin became very popular, the dividing line was this. The women who had hysterectomies were given Premarin with the belief that they didn't need progesterone because they didn't have a uterus anymore. But the
Common.
women who still had uteruses and went into menopause, they were given Prem Pro, so that there was this progestin in there that would balance the estrogen that they were given in Premarin, and they wouldn't bleed. This is rational. However, the world of traditional medicine grew up with this belief that if you had a uterus, you needed Prem Pro, and if you didn't have a uterus, you didn't need the progestin part, you just needed Premarin. And that has been doctrine for years and years and years. So it's very common for a woman who's seeking treatment from someone who is not specialized in treating women with ovarian hormone replenishment. It's extremely common for them to run into the recommendation that, listen, you don't have a uterus, you don't need progesterone. And so that's very common. Now, progesterone has so many more functions than just balancing the estrogen and preventing overgrowth of a uterine lining. It's fabulous for bones, for example, or it's important for bones. For
Yes.
example, progesterone is the only biochemical that I know that supports the cells called osteoblasts that lay down new bone. Progesterone is extremely active in the mood of women.
Yeah, that too, for sure. But either up or down. I mean, that's the whole.
No, it's one way.
Really?
Women, there's so many women on this planet that as they lose their progesterone, they start getting into very challenging mood issues, including anxiety and depression.
Yes.
There's many women who are put on mood stabilizers or mood active strong medications in menopause when why their mood went wonky is they lost their progesterone and their estrogen. Progesterone is very important, but there's no absolutes in medicine. If a woman can't get progesterone, the key word in the questioner was she's terrified, I think was the word.
She's extremely concerned because she does want to protect her.
Okay, there's a medical diagnosis, or shall I say it's a human diagnosis, called extremely concerned.
I'm sorry for laughing.
It's a very important clue to the emotional approach to life, and it needs to be taken on. And I heard about a young man who spent years in therapy trying to sort out what happened with the mother who wasn't present for him. I just heard about him before you and I got on this call, on this FaceTime Live, Facebook Live. So this is an issue. And, better living through biochemistry is not going to address the emotions in the mind, and challenges like this pop up in midlife.
Yes.
And so midlife calls, if you haven't done it before, midlife, I was fortunate enough to put my shoulder to the wheel around emotions in the mind in my early 30s, as I discovered some deficiencies I had
No
in
way.
relationship that led to divorce, and that was very impactful. So I went into therapy, etc., in my early 30s. One of the best things I've ever done in my life. So when I hear this is one of those things that you want more information. It may be a clue to that one of the major tasks this woman has is dealing with the emotions, because you don't have to be extremely fearful. Now, I don't know this questioner, but I did want to take this opportunity to mention that there's many challenges of midlife. It's called, oh my God, the change of life. That used to be what menopause was colloquially known as. Well, what does that mean? It's real. For many women, for example, the child rearing ages are over and you're in a new phase, and you got an empty nest and you're faced with yourself, and you're heading towards the next life stages that call for enlightenment, and everything that you don't know, and every emotion that you haven't healed, and every dysfunctional thought that isn't the truth but you think it's real that you haven't dealt with, they're up for grabs, and they're going to come boiling up to the surface for many people. No problem. What you do is you address what's there. And so if you've got a work to do in the world of emotions and the mind, you find your way to information, tools, and support that help you address that. So that's a little bit of a diversion there, but it was an important part revealed in that question. And yeah, we're talking about progesterone.
Well, we are, but also I, admittedly will say I am, part of that extremely concerned tribe. I'm not as extremely concerned now because I have been able to do a lot of the work. But ooh, that extremely concerned thing is very important, Dr. Rosensweet, and you have brought this up many, many times.
Yeah, I
Important.
mean, of course we care. Of course, concern is often the clue that there's something we got to pay attention to and figure out what the right thing to do is. But if it brings over to extreme concern, I mean, we should be extremely concerned about COVID, in my own personal opinion, and how to protect ourselves and others from the damaging parts of the life-threatening parts of this pandemic we're dealing with, and the underlying health concerns. Now, that's something to be extremely concerned about. When someone loses a job, that's an extreme concern. When marriages are in threat for divorce, that's extremely concerned. Not getting progesterone, I'm not going to throw it in that category. This is not an extreme concern. You can live without progesterone. So you want to take it on. And now I have a different feeling. I'm not going to call it extreme concern, but about the loss of estrogen and testosterone, both of them. A woman who does not replenish her estrogen, for example, it's almost a certainty that over the course of time, she's going to get adverse results. She's going to have adverse outcomes from not having her estrogen that are a big deal. And the same is true for testosterone. If a woman, testosterone is not a male hormone, it's a human hormone. Women need testosterone. That's very important. And I do have extreme concern, and I've seen many examples of women who, I mean, every woman loses her estrogen and testosterone midlife. Every, not some. Every woman loses her estrogen. When your periods have stopped, you didn't zero out your estrogen. You still got some estrogen, but it dropped very low. Now, I have concern about that because something as simple as replenishing estrogen can make a world of difference for a woman. And sooner or later, midlife, no, certainly, I've never seen it to be true 3 years after the loss of a period that women also haven't lost their testosterone. Some women enter perimenopause and are still cruising on some adrenal testosterone as well. But 3 years into no period, that testosterone is disappearing. And when your testosterone disappears, the likelihood of you losing your muscles, whew, Take a look at the elderly, women in their 70s or 80s or 90s. Like you mentioned, they have lost so much muscle that they're not walking or standing with stability. And they sooner or later wind up with canes, walkers, and then that transition time to wheelchairs because they can't stand up and walk. They've lost their muscular strength. Sarcopenia is that's known as. Every gerontologist on the planet Earth will tell you what's the bane of the elderly? Sarcopenia. Yeah, we got lots of diagnoses possible. Diabetes, high blood pressure, et cetera, et cetera, et cetera. But the sarcopenia is what's doing in most of the elderly and making them have to change from walkers to wheelchairs. And that is a special time because for many, they can no longer take care of themselves and take care of themselves at home. And they transition, if they have the funds, to assisted living or nursing homes.
I see this. I do see this. I see
God
the
bless nursing homes and all the devoted caretakers and professionals that are taking care of the elderly. It certainly has a soft spot in my heart for. There was a point where I could no longer assist my elderly mother.
Yes, I know.
So at the same time, women are not thrilled by shifting out of their homes into assisted living facilities or nursing homes. And one of the biggest things in the world that you can do to prevent that is start replenishing those androgens, testosterone, the queen of the androgens, testosterone, the queen of the androgens. I'm trying to shift people's consciousness about what the heck this testosterone is. It could do. I was talking this over with Dr. Lindsay Berkson, a dear friend and an expert.
Amazing woman.
we were discussing what would be the change in an American medical practice and in Medicare if hormones were replenished. What would happen to nursing homes? Their populations would go way, way down because the women wouldn't need to go in there just from the prevention of sarcopenia alone with adequate androgens, testosterone, and estrogen. Oh my God. Cognitive function. A lot of women are in assisted living facilities because they've lost cognitive abilities. And they've lost it primarily. Well, there's a lot of reasons you can lose cognitive function, but the major reason for women is loss of estrogen, loss of bones, loss of estrogen, loss of arteries, heart attacks. Half of us who leave Earth because of complications of cardiovascular disease, arteriosclerosis. Women have special protection against arteriosclerosis from estrogen. Woman loses her estrogen. Women have a much lesser heart attack risk in their 40s than men do. But the risk equalizes in women and men about the age of 60. Oh, guess what the difference is? Loss of estrogen. That estrogen is protective to your arteries and your brain. So when a woman has strong concern because of loss of progesterone, I don't feel that way. You know, I love progesterone. We prescribe progesterone to every single woman in menopause. And 99% of the women that we prescribe progesterone to, they do just fine with progesterone. And there is that certain small percentage of women that do not do fine, and we've got a challenge. But, you know, healing's possible. We figure these things out. However, I do have significant concern for women who lose their estrogen and don't replenish it, and women who lose their testosterone and don't replenish it. They still live and they still navigate, but they may not have bladder control. They lose the health of their vaginas. They can't have intercourse because of the pain, and on and on and on. Arteries, brain. So the real concern is when we can't treat a woman with estrogen and testosterone. And you know what? In my practice, 25 years specializing with women in menopause, I have never encountered a woman who doesn't receive estrogen in the form of bias or testosterone just beautifully, no problem. They do great. Yes, there is the occasional woman who doesn't tolerate progesterone, but to me, that's not as critical. Whereas loss of estrogen and testosterone is critical. So that is a real concern. But it's so easy to replenish it. That's the thing. Women tolerate without exception in my 25 years. I'm sure there's an exception out there, a woman who doesn't tolerate estrogen or testosterone, but I haven't seen it. I'm talking about a lot of patients there. I'm talking hundreds and hundreds and hundreds of women.
Yes, I actually wrote that on our group.
Women
Yeah.
women do really, really, really beautifully with estrogen replenishing and testosterone replenishing. And there's a rare woman who doesn't do well with progesterone. Rare.
But you don't really, you are very, yeah, you've just explained it, that you're not as concerned with the inability to handle progesterone as you would be the inability to take estrogen and testosterone, because those two, yeah,
Precisely, Carolyn.
yeah. And I see it. Oh, do anyway, we won't go there because I have to.
There from Tanya, who said, I'm unable to take estrogen because it triggers my migraines. However, I'm going to say, yeah, get thee to an expert because, yes, getting estrogen right for those who have migraines, but I'm going to raise the possibility that someone just hasn't figured out your recipe
Mm-hmm.
because migraines are often triggered by too low estrogen, especially in young women. So I'm going to raise the possibility, Tanya, that someone, and you need an expert who really understands bias and don't give up on estrogen. I'm going to say that there's a way to figure you out, and also there's other things that trigger migraines. So that's a whole other issue. I'm not saying that you haven't concluded something that happens to be correct for you, but I'm going to suggest that, well, I don't know. Give an expert a chance at this, and it's liable to be you are able to tolerate the right estrogens in the right dosages in the right balance with progesterone and testosterone. You
Right.
certainly, when you were younger, you certainly tolerated rather robust levels of estrogen when you were younger. What happened there? Some magical, all of a sudden, estrogen causes migraines? No. There's a story there, and in most cases, it's unravelable. Yeah, you can unravel it.
It's unravelable.
You can get it right. That's what I really want to say. You get it right, but you're probably going to need an expert to do that.
Right. And as we started off, and we talk so often about, thankfully, people having passion to, yes, really embrace menopause and the treatment of treating
Get,
women.
get expert at it and take it on as a specialty and get expert at it. And as the menopause method, that's one of our major missions is to train and mentor physicians and nurse practitioners in prescribing or advising compounding pharmacists on how to become an expert at this. Take it on as a specialty. Get expert at it because there's so many moving parts. It's like anything else in medicine. A general practitioner could set a fractured bone,
Right.
but oh my God,
Right.
that is a wrong choice. You want to go to an orthopedic surgeon. These folks have been phenomenally trained in fractures. They've had a surgical residency, then they had a 1 or 2 or 3 year orthopedic surgery residency. They've been mentored by experts who know how to set bones. They are able to hunker down and study everything that's known about setting bones, and that body of knowledge is vast. You want to go to an orthopedic surgeon if you fracture anything. You do not want to go to a general practitioner who could probably figure it out in some crude way, but you could wind up hobbling or having a dysfunctional limb because you don't want a general practitioner to be setting your bones. They're going to
Right.
do they're going to do better than an auto mechanic most likely because they've been somewhat trained minimally. I had a 3-week externship in orthopedic surgery as a medical student. I know a few things, but you want an orthopedic surgeon, you want a specialist. Well, there's a similar thing in the world of treating menopause. There's so many moving parts to get it right
Right.
that you want to get an expert to hunker down and figure it out and do the proper testing called 24-hour urine hormone testing. So that's what I recommend.
Thank you, Dr. Rosensweet, for that. Yeah, you don't really want to see your podiatrist to prescribe your hormones, I guess, but they might know how. I don't know. They're great. Question comes in from somebody very, very, very new to menopause, and she is still cycling, meaning she's having her periods, but she seems to be getting sicker and sicker and sicker, just like during her cycle and a little bit after her cycle. She feels great the week before, and she's wondering, again, back to progesterone, if she needs progesterone starting right after her cycle. And she wants to know if a progesterone birth control pill would be the most helpful.
Okay. Well, as often is the case, our next step with this particular woman would be to know a lot more about her. Because the question is very important.
Oh, yeah.
But in order to give her right recommendations, we would want her to fill out a 12 pages of questions, and at least 4 of those pages relates to hormone balance. But I'm going to make some guesses based on what's most common. And I'm going to recommend our book, Happy Healthy Hormones, which Carolyn has made accessible, no charge, the PDF version on Carolyn's Facebook page.
It's right there at the top.
Because we go into this description. And the hormones, estrogen and progesterone, in a healthy young woman are exquisitely balanced. Just like a zillion things that take place in the human body. Think about it. Everyone who's listening to this Facebook page, heart is beating. It's astounding.
No, it is. And the blood is going out and going in and being oxygenated and
breathing. And a zillion things like this are taking place below our conscious control or knowledge or attention to it. And hormones are being sent out there. They're being manufactured in our cells, and they're being distributed. It's just a phenomenal orchestration. And a young woman to get a period to happen once a month to prepare for possible impregnation and fertilization and implantation and pregnancy and breastfeeding. Oh my God, this story is so complex and staggering. If you don't believe in the divine, study the female menstrual cycle. Who figured this one out? Oh my God. And in many of women, that menstrual cycle, the orchestration of it is very predictable, and it has a balance of estrogen and progesterone and a timing of output and bursts and levels, and you'll see it all graphed out in our book, Happy Healthy Hormones. Now, does that balance exist in all women? No. Young women can get thrown out of balance, And by the perimenopause, a lot of imbalances can take place. So a young woman's estrogen levels and her progesterone levels are going to be their absolute maximum approximately the age of 20, plus or minus a couple years. Maximum output. And then those estrogen and progesterone levels, here's estrogen, here's progesterone, those levels start declining. And then they undergo a major droppage, not a complete dropout, at menopause, and you stop menstruating. Now, that's one way they can decline, together holding hands, maintaining the same balance. Oops, that's not all that common. It's very common for, if this is progesterone and this is estrogen, well, I'm going to do that backwards. If this is estrogen and this is progesterone, for the progesterone decline deeper and quicker than the estrogen, and you get into an imbalance situation there. That can happen before the perimenopause. That can happen to a woman in her early 30s. And we go into this in the book because one of the best things a woman can do is identify when that imbalance starts, when her progesterone is no longer balancing her estrogen. She's getting something called domination of those estrogen effects without the balance of progesterone, otherwise known as estrogen dominance.
Right.
Common, and the earlier a woman can pick up on this and start replenishing progesterone, which you can do even over the counter. We recommend linking up with an expert. We recommend dispensing these hormones in organic oils for a lot of reasons. But, you can get over-the-counter progesterone that can do a 30-year-old or a 35-year-old a lot of good. And so, yeah, one of the most common things that's happening in the perimenopause is insufficient progesterone. So get it going. Read our book. And here's your main job.
Hmm.
I've said many times, to the best of your ability, go out there shopping. And it may take you a while. A lot of things take a while.
Back to that acceptance thing.
To get the right everything and to get wise enough and skilled enough to do just so many things that are important, they take a while. Sometimes shopping for someone who's specialized in treating women in menopause with compounded bioidentical hormones, sometimes it takes you a while to find your right provider. But the recommendation I'm making is take that project on. Ask your friends. Ask your network. Do you know anybody who's taking hormones in our network? Anyone's mom? Do they like their provider? Is their healthcare provider seem to be a good person and kind and really caring about this subject? Have they gotten any extra training? You got to go shopping, because your main job in the perimenopause is go find someone who knows what they're doing. They're going to have to write prescriptions. We believe, my team believes, my partners believe that we're going to be able to get this so refined that, given the woman the knowledge, were it true that they could get hormones without a prescription, they could figure it out. That's what the book Happy Healthy Hormones is about. Because in the beginning of treating women in menopause, there was very little knowledge, and these hormones were going into an individual woman's body. So I wrote that book thinking that if I give this to my patients and they know it's a certain amount, they don't have to go to medical school, about how these hormones behave and how it shows up when they're insufficient, that together we'll be able to figure it out. I'll write the prescriptions. They'll start at low dosages and gradually increase them. They'll alleviate their symptoms of insufficiency while not going into symptoms of excess of 4 different hormones. And we'll figure it out together. Well, we have a belief, and especially my team does, that with AI and computers, they're designing the program right now. I was talking to one of my partners, my son, who he's already designing the AI so that a woman could just plug in her data and the computer is going to spit out what the adjustments a woman should make to her hormones. So
It's incredible.
I
Yeah.
know we're trying to uptrain individual women so that when they don't have a provider, if the provider will just write the prescriptions, this is a hope for our future, that individual women can figure this out. And we have a pilot program going of women that we're giving them the book, we're giving them the tools, we're giving them the app, and we're giving them the hormones. And these happen to be friends of mine. And we're not doing, I mean, that sounds pretty wild. And we know how to monitor because bottom line, we want breast health.
Very exciting. And our last
So at any rate, here's the bottom line. At this stage, your job is to find someone who knows what they're doing and get educated yourself. Start with happy, healthy hormones. And between you and your provider, you can figure it out. And get your dosages of estrogens in the form of bias, compounded bioidentical bias, testosterone in the form of testosterone, topical estrogen, topical testosterone, progesterone, topical or oral, DHEA, topical, easily combined with the testosterone or oral. You can eventually arrive at the proper balance for yourself. And it may need some coaching, and it may need someone, because sometimes it's not a straightforward process. So progesterone matters, and Carolyn, I have no memory whatsoever of what that question was. I think it had to do with progesterone, did it not?
There was no question. No, I'm just kidding. Yeah, it's fine. It's fine. It's fine. She was learning about anyway. You answered it.
Okay, let's
yeah.
go on.
This is a question that does come up really often. My doctor told me that they only look at symptoms, and why is it that they won't take tests? They're giving me hormones. And this is like usually in the first couple of months, 3 months, whatever. And many women just don't understand that, and they get rid of their doctors right away because they don't test them right off the bat. Have you heard that story?
Oh, yeah.
Mm-hmm.
In the world of menopause, the biology always comes down to this: loss of ovarian hormone production. And in the world of treating women with hormones, in the primitive days, a woman was given primarily, usually, Premarin or Prempro. Premarin in combination with an artificial progesterone known as a progestin. And there was only 1 or 2 dosage forms. And this started, in the 40s or 50s? Premarin really came online. In fact, Premarin and Prempro were the most popular and profitable drugs in their day for pharmaceutical companies than any other drug that's ever been given up until that time. And 40% of American women in menopause, grand total 18 million American women by 2002, were being treated with hormones. And the 18 million women were being treated in menopause with hormones. And I want to tell you that these women did so much better than the women who are not being treated. And they looked different, and they felt different. And there was only 1 or 2 dosage. And testosterone was not being given. And yet these women did better than women who were untreated. And these women who were being treated with Premarin and Prempro were at less risk for breast cancer, heart attack, and stroke than women who were not being treated with hormones.
Did they have to test?
I'll get there, thanks. Yeah. I want you to know that back in the days when things were crude, I mean, back in the day, 1,000 years ago, Chinese aristocracy were getting young men to pee into special containers and young women to pee in special containers, and they were drying out that urine, and the aristocracy were taking that dried out urine in the form of, they were put into some kind of pill form, and they were taking them. So this just changed to horses in the 40s or 50s. Instead of using young women and young men's urine, they were using horse urine. So I just want to say that even as crude and as unexact as that was, these people did better. There was no way to test for Premarin.
Right.
So there was no testing being done. And when you try and test a woman that you're treating with blood testing or salivary testing or other methods other than the 24-hour urine hormone testing, even if you're using compounded bioidenticals, you've got to use 24-hour urine hormone testing to really understand. So doctors know that blood tests, in fact, they're being told by the North American Menopause Society and the Society of Endocrinologists that testing doesn't really work in menopause women. That's the gospel, and you don't need to do it. And that's not wrong. The testing that does work is when a woman's on compounded bioidentical hormones and she's tested with a 24-hour urine hormone collection, 24-hour urine hormone testing, not the urine 5-point or peeing on a filter paper. When she's being tested by 24-hour urine hormone testing, that testing's exquisite. You and I are on this call today because I discovered 24-hour urine hormone testing over 20 years ago. And I got to correlate. That testing's great. But there is a certain amount of benefit, of accuracy when a doctor says, I don't want to test you because blood testing, the gold standard for so many things, doesn't really work when you're treating a woman. When do you draw the blood? Just before she applied her hormones? Just after she applied her hormones? 2 hours after? 4 hours after? By pharmacokinetics, I'm not going to go into the details now. You got a real challenge on your hand. And so many women are going to feel better. They got a lot of symptoms. 75% of women have some pretty raucous symptoms in menopause. Hot flashes, can't sleep, night sweats, all kinds of stuff, mood disorders, cognitive difficulty. Then when you start treating women with hormones and they start feeling better, and then they say to the provider who wrote those prescriptions, I feel better, that's satisfactory, just like the women who got Premarin and Prempro. Now, lo and behold, I used to, a colleague of mine and I were given a full day to train physicians at a very large conference once a year. And before every yearly conference, I would ask myself, I wonder what I've learned in this year. And one year, quite a long time ago, I looked at 54 24-hour urine hormone tests on patients of mine who said, I feel good, doc. We figured out the dose. I'm doing good. I looked at the 24-hour urine hormone testing, and because I've gone into the medical literature and I know what the optimal range, for example, of estrogen is, what's too little and what's too much, I know what that is, and I've defined it, and the laboratory we work with actually publishes that in the Menopause Method report form, the 24-hour urine hormone laboratory. And here's what I discovered, that when 100% of these women said, I feel good, I found my dose. It might take them 2, 3, 4 months to do that, 5 months to do that, some even longer, but they all said, I feel good. Here's what we found. 25% of those women were in the optimal hormone range zone for estrogen. 25%. Where were the others? Where was the 75%? 50% of those women that I tested, they were on doses of estrogen too low to protect their vagina and their bones. What? They felt good, but 50% of them over time were still going to lose their bones and their vagina. Not to mention their cognition and other stuff. And 25% of them were on estrogen doses more robust than we accept for a woman in menopause because they were at risk for producing breast glandular cell proliferation. So as the field evolves and you get deeper and deeper into the details, I haven't taught for many, 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 many years that it was okay to listen to a woman say, I feel better. No, we want to confirm that with 24-hour urine hormone tests. When a woman's on compounded bioidentical hormones, that's fabulous combination there. And then we do some tweaking because 75% of them are not, they might feel better, but it's unlikely that they're on the proper doses. 50% of those women who feel better are going to, and according to the study I did of my own patients, are going to be on estrogen levels not sufficient to protect their vagina and bones. They feel better, but they do not have enough estrogen to protect their vagina and bones. And 25% of them are going to feel better, but they're going to be at risk for breast glandular cell proliferation, i.e. cellular mitosis in their breasts. We don't think that's a good thing to do for most, not all. There are exceptions. Some women really need robust estrogen levels, even enough to bring their period back if cognition is at stake. So there's always exceptions. But what I'm saying is the field has advanced so much that what served women in the 50s and the 1960s and the 1970s, all the way up to 2000, Premarin and Prempro, served these women. You talk to these women, as I have. They like that stuff. They felt better, and they were watching their compatriots not feel better, but they were feeling better, and they were benefiting. But the field has advanced enormously in the 80s with Dr. Wright and Jim Herntzer, two pioneers, both independently, coming saying, why don't we do bioidentical molecules? They're available. Why don't we put them up in topicals? Because topicals are better for estrogen and testosterone. Thus started the move towards compounded bioidentical hormones. And so the field has evolved. So nowadays, when someone says, my doctor is saying that he doesn't need to test, I understand that. If they haven't discovered 24-hour urine hormone testing, they're going to come up with that statement, I don't need to test. And they're going to really rely on women saying, my symptoms have improved. Well, these women who are seeing providers like that are doing monumentally more terrific for their whole life than the women who are not being treated. So you want to celebrate, you got a doctor who knows enough to say, let's alleviate your symptoms, give you the proper give you hormones to do so, and you're a jillion miles ahead of women who are not being treated. Now, the field has advanced, and if you want to really get into the world of expertise, you got to go further. You want to now find the providers who say, well, no, I do test. I use 24-hour urine hormone tests. I test when you say, most instances, that you feel better. Well, great, we're going to test you then. And 75% of the women that we test when they feel better, we're going to need to tweak those dosages a little bit, not a lot, because it's going to get you near the zone when you feel better. So you're doing fabulously better than women who are not being treated by just getting near the zone. And then go on to the next level of expertise where we do a 24-hour urine hormone test at that moment, and then we do some dosage tweaking. These dosages, when a woman feels better, are never that far off. So when we tweak the dosages, we don't say, and now we're going to test you again. We don't have to. The women who feel better, they're going to be close. They're not going to be in the optimal zone, 75% of them. 25% of them will. But 75% of them, according to the study I did myself, are going to need some tweaking. But I don't retest them. We do the annual 24-hour urine hormone test. We wait a year to test them because we can tell that the tweaking is going to get them close to where they need to be and put them in the zone. So the time has gone past, it's surpassed our opportunity for today, and I need to sign off.
I guess I must say goodbye then.
Yeah.
David Rosensweet, MD, amazing man that you are. Thank you for today. You've answered the questions wonderfully, as you always do. Ladies, thank you for coming up. Happy weekend to everybody. May we all feel well. And I got the questions, and we're just going to keep answering them.
So
right?
We'll see you next Tuesday.
We will indeed. Have a great, wonderful weekend, everybody. Dr. R, thank you.
Thank you, Carolyn, for making all possible. This is possible because of Carolyn Shapiro. Thank you so much.
It's my pleasure, believe me. Yes.
Have a good weekend, everybody.